coming to the very basic question that being a pediatrician, how one is supposed to approach a child with suspected lymphoproliferative disorder. And as like any other pediatric condition for that matter, the clinical approach is again based on three important stones, which are taking a thorough meticulous history, good physical examination, and initial evaluation. Being a pediatrician, obviously the very important aspect will be that how one approaches a child with suspected lymphoproliferative disorder. And as like any other childhood condition, it again depends on three important stones, which are your history, thorough physical examination, and then only you can plan your initial evaluation. So how is history important? The importance of taking a thorough history cannot be overemphasized. Taking in account the age, the duration of the illness, presence of constitutional symptoms or the so-called B symptoms like fever, excessive weight loss, night sweat, having bone or joint like osteoarticular symptoms, they are of paramount importance. History of any recent travel can give you valuable clue for any recent infection that the person has acquired, and obviously a detailed immunization history has to be taken into account in such situations. Physical examination again is of paramount importance. Attention should always be paid to the vital parameters, especially when we're dealing with malignant lymphoproliferation, because many of them can have critical physiological disturbances and the instability by the time the child presents to your department. So can have issues like airway problem because of a massive mass in the mediastinum or a bulky cervical lymph node. They can have something called tumor lysis syndrome, in which they can present with metabolic catastrophe. They can have bleeding symptoms if it is a hematological malignancy. So before we go to a detailed systematic examination, it is always just like any other pediatric case, give attention to the A, B, C and see whether the patient needs any immediate attention for the physiologic stabilization. Now, while you now gradually want to do a systematic examination and try to narrow down your differential diagnosis, the extent of lymphadenopathy, whether it is just localized versus generalized lymphadenopathy, whether some particular group of lymph nodes like epitrochlear node, left supraclavicular nodes are enlarged, they are of quite clinical significance. The clinical phenotype of the node, that is what is the size, whether they are firm or rubbery in the consistency, whether they are single or they are multiple, whether they are clumped or with each other or the matted, whether they are mobile or they are fixed with the underlying structure, is there any overlying skin changes, any fistula formation or the draining sinus of the overlying skin. All these things has to be taken into consideration. And obviously systemic examination and a head-to-toe examination to look for any rash, mucocutaneous bleeding, any osteoarticular abnormalities should be examined. And then obviously your plan of initial evaluation should be tailored according to your history and physical examination, by which time you must have narrowed down your differential diagnosis. And this initial evaluation, it can range from none, like for example a child who recently had a viral infection and then obviously has developed generalized subcentimetric lymphadenopathy. You will probably not do any evaluation but to just reassure the family. And at other end of the spectrum, it could be an exhaustive evaluation, which may include extensive microbiological evaluations, rheumatological evaluations, immunological evaluations, imaging, nuclear imaging, etc., etc. So as I said, I think this protean term I'm using again and again. So the clinical manifestations can be protean, and accordingly, your approach to the diagnosis and the diagnostic evaluation can again be quite protean, ranging from none to exhaustive workup. But usually, most of the situations one does initial evaluation is doing a complete blood count with peripheral blood film examination, plus minus with ESR and a chest X-ray. So these are the initial evaluations usually being done, but again I'm emphasizing that it needs to be individualized. Now, the million-dollar question, being a clinician, how do you differentiate a benign from the malignant lymphoproliferative disorder? Is it totally in the hand of the histopathologist, or does the clinician also get important clue? Yes, the clinicians can get very important clue provided a thorough clinical evaluation has been done. So let me tell you, like for example, the clinical course of the disease, whether it is an indolent clinical course versus ultra rapid, abrupt, stormy course gives a lot of clue to the differential diagnosis, like the usually indolent clinical course. So, for example, the clinical course of the disease gives very valuable clue to and gives an insight into the type of lymphoproliferative disorder you are dealing with. Like for the example, for the benign lymphoproliferative disorders, the clinical course is usually indolent, like for several months sometimes. But for the malignant lymphoproliferation, usually they are rapid, abrupt, and the stormy. Within a few weeks or few days, they present to the clinician. But indeed, there are exceptions. Like for example, Hodgkin lymphoma. Despite being a malignancy, it usually has a very indolent clinical course. So I'm obviously saying that there are certain clinical clues, but nothing is very sacrosanct. Then the characteristics of the lymph nodes, if you see. So in benign lymphoproliferative disorder, they're usually discrete, small, freely mobile nodes, but again there are exceptions, rare exceptions indeed, like for example Rosai-Dorfman disease, in which you get very massive cervical lymphadenopathy. Vis-a-vis for the malignant disorders, these lymph nodes are generally conglomerate, large, they're adherent to the underlying structures. What about the extranodal presentation? They're usually unusual. They are generally unusual for the benign conditions, but for the malignant conditions, they're often present, especially in the children. Extranodal presentation with involvement of the abdominal structures, involvement of gut, involvement of kidneys, skin, liver, subcutaneous tissues, bones, and osteoarticular system. They're quite common to happen with pediatric malignant lymphoproliferative disorders. B symptoms could be present in benign or malignant, both the condition. It cannot really differentiate. And as I have iterated at the very outset, the pathology is going to be showing polyclonal lymphoproliferation in benign conditions, and usually they have low proliferative index on the histopathology. Vis-a-vis, these are quite monoclonal in the malignant disorders and high proliferative index. There are certain different markers of proliferative index. Some of these are like you must have heard of Ki67, MYB index, etc. So these are certain proliferative index that histopathologists do commonly use, and malignant lymphoproliferative disorders usually show a high Ki67 level and high MIB index. Coming to the list of benign lymphoproliferative disorder, as you can see, the list is quite exhaustive, but let's talk about the common conditions. Number one, infections are the most common reasons for benign lymphoproliferation in childhood. And this infection could be anywhere ranging from EBV, CMV, dengue, and the other different arthropod-borne viral infections. Bacterial infections, again, tubercular etiology is quite common in endemic countries like India, rickettsial infections like strep typhus, etc. There could be other reactive etiologies apart from infection like trauma, surgery, etc. But definitely that leads to localized lymphadenopathy in the territory, right? Rather than, and not a generalized lymphadenopathy. Autoimmune rheumatological conditions, for example, systemic lupus erythematosus, systemic onset or systemic juvenile idiopathic arthritis, Kawasaki disease. So they are common pediatric causes of autoimmune causes of lymphoproliferation. Sometimes drugs like phenytoin, interferon directed therapy can result in generalized lymphadenopathy, mimicking like a lymphoma. Immunodeficiency, which could be acquired like due to HIV/AIDS infection, or could be conditions like post-transplant lymphoproliferative disorders, autoimmune lymphoproliferative disorder, and different primary immunodeficiency disorders in which there could be lymphoproliferation as a part of the disease process in itself. Like for example, common variable immunodeficiency or CVID, X-linked lymphoproliferative disorders, etc. And then you have certain rare conditions which are associated with bulky lymphadenopathy usually, for example, Rosai-Dorfman disease, Castleman's disease, and Kikuchi disease. I will try to touch upon all these conditions and give you some information in nutshell. If I have to talk about the management, a very general outline of the management of the benign lymphoproliferative disorders, as you can understand that these conditions are pretty much heterogeneous, and the management obviously has to be tailored and individualized or customized accordingly. So for several conditions, you just do wait and watch. For example, self-limiting viral infection, drug-induced lymphoproliferation, in which you just stop the inciting drug and the lymphoproliferation gets taken care of by itself. In many conditions, especially the infection-associated generalized lymphadenopathy, what you just do is treat the underlying infection or underlying condition, either with, let's say, antibiotic or immunomodulation. The conditions which will require immunomodulation includes your PTLD, post-transplant lymphoproliferative disorder, in which B-cell directed therapy has to be provided, autoimmune lymphoproliferative disorder, Rosai-Dorfman disease, So in this group of conditions, you need to provide immunosuppression or immunomodulation in order to treat the lymphoproliferation. And then you have certain benign, so-called benign lymphoproliferative conditions in which the burden of symptoms, both local as well as sometimes systemic, could be so overwhelming that you need to end up treating them with systemic B-cell depleting chemotherapy, like for examples conditions like Castleman's disease, and even post-transplant lymphoproliferative disorder, you might have to opt for chemotherapy for adequate disease control. So as you can understand, therapeutic armamentarium for the benign lymphoproliferative disorders is quite wide.